Thank you.
Thank you very much. Thank you, Professor Maciel. Thank you for the introduction, and thank you to the organizers for inviting me to give this presentation. It is my honor to be with you today. I'm only sorry we are not there in person, but I look forward to one day in the future years where we can get together in person. So I was asked to speak about epidemiology in the current moment. We have all been living through, and we are all living through the COVID pandemic, as everybody knows. And what I would like to do is offer some reflections on how I think epidemiology has done in the context of COVID, and some things which I think we have not done as well as we should have done, and really with an eye to what we could and should do better in the future. Obviously, the pandemic is not over. It's not over in Brazil. It's not over in the United States. But I don't think it's too early to start thinking about how we, as epidemiologists, should be evaluating our contribution during this time. So I will share my screen. And so not knowing exactly what people got or not, I'll do a quick summary. I said I'm going to talk about COVID I'm talking about epidemiology in a time of COVID. And what I'm going to do in my talk is draw on what happened in COVID to draw lessons for epidemiology that I think can apply, not just in a time of pandemic, but more broadly speaking. And I start off by saying that it has been a good year for epidemiologists, and it's been a good year in many ways. I know that we've all been through this moment of COVID and are still going through a moment of COVID, and it's hard to think of it being a good year, but it was a good year in many ways. This is from a column in the New York Times, an important newspaper in the United States, which calls epidemiologists the new rock stars. And the same newspaper, this was last year for the American holiday of Thanksgiving. This is coming up this year, but it was last year about this time, was the newspaper was asking epidemiologists what they were doing for Thanksgiving and asking epidemiologists what they're doing for Christmas holidays and for other vacations, which really reflects, I think, the greater visibility of epidemiology as a discipline. But while it's been a good year for epidemiologists as a discipline, we have to recognize it's been a terrible year for the world. This is a map of the world showing the density of cases of COVID-19, with more than 5 million deaths we've had in the world, more than 200 million cases at this point. And the world has been through many waves of COVID. This is a simple map of the surges of COVID. This is a map of the United States at one point during COVID-19, showing how the whole country really felt like it was on fire. I suspect there were times in Brazil where you also felt the same way. And the deaths really were not just coming from COVID, but from all sorts of other places. This here looks at excess mortality. And in 2020, the gray lines at the bottom are mortality in other years, and the black line being the average, while the red line shows the higher mortality over baseline that we've had around the world. In the United States, COVID-19 has been the third leading cause of death in 2020 after heart disease and cancer. You can see on top, heart disease, cancer, and then COVID-19. And which is really dramatic for a disease that we had never heard of before December 31st, 2019. And I would argue that if I told you today that there's going to be a disease in 2024 that you've never heard of, that will become the third leading cause of death in Brazil, you as epidemiologists would say, well, we should be thinking about that and doing something about it so that we can prevent it. And that's what COVID has been. So while it has been a year of prominence for the discipline, we have to recognize that the goal of the discipline, which is to understand disease so we may prevent it, didn't really go very well for us, and that we did not do a terribly good job at that. Now, nobody's really blaming epidemiologists for COVID-19, but perhaps the world should, or at least if not that, then we should look at ourselves and say, what are the things that we did that we could have done better? So I would argue that the integrity of epidemiologists faces some challenges, and I'm going to focus on three of them. I will focus on false certitude, on contradiction without acknowledgement, and intolerance of disagreement. I will start with false certitude because much of what happened during COVID-19 has been informed by epidemiologists' effort, particularly modeling epidemiologists, what's going to happen around COVID-19. Now, those efforts we know have largely been unsuccessful. COVID-19 has behaved in ways that were very hard to predict. Despite that, of course, we've had multiple disease models that have informed public policy that have been very important for governments and for our efforts to try to understand when to open society or not, even though these and wrong with our models not being accurate, since of course we recognize that models are ultimately based on assumptions that often embed quite a bit of error. But that, of course, has the fact that we have presented these models with a sense of certitude and a sense of clarity about the fact that we are right about what we're doing has resulted in now the backlash that's beginning, the failures of influential COVID models. And these are articles in the United Kingdom. Long known that we have to be cautious about models. And this is a quote about paper on modeling. With a lot at stake, it's best to be humble when faced with fundamental limitations. Models are usable as long as they take into account certain assumptions on which they are based and the data. If this is not the case, the results are on a power of assumptions or guesses. Much as what is from our modeling has been assumptions and guesses. Not presented things that way, presented things with a certain certainty that mind far outstrips what we actually knew and when we actually knew it. And I would argue that the reason for our doing that was a discomfort with admitting the level of uncertainty that informed what we were doing in a time of COVID. Of course, there's no reason why we should be uncomfortable about uncertainty, although perhaps, except perhaps for ego reasons, because we know that the public can handle uncertainty. This is from a paper that looked experimentally at communicating uncertainty, concluding that communicating uncertainty exerts only minor effect on trust. Knowing this should allow academics and science communicators to be more transparent about the limits of human knowledge. And I would argue that we have failed at being transparent about the limits of our knowledge with our efforts in with our false certitude. A corollary of this has been our reliance on contradiction without acknowledgement. Science, of course, happens with steps forward, steps back, with findings that then counter other findings, with findings that contradict each other, and that's perfectly fine. But to move science forward and to move understanding forward, we should be honest and upfront about just that, about that the changing in science. But we have not really been that upfront about this. This is an example of this, perhaps, comes from the changing science around mask wearing, where initially we said that mask wearing did not have that much of a role, but then science suggested that mask wearing did reduce viral load, and it was played an important role in mitigating the virus, which again is totally fine. But rather than acknowledging that as part of our uncertainty, we've essentially gone on to sort of trying to delete the past and to ensure, as this newspaper put it, to ensure current public health guidance is clear, when of course there shouldn't be any reason why things are not clear just because we had uncertainty. And third, and perhaps most worrisome, has been intolerance of disagreement, that orthodoxy in science formed very quickly, particularly orthodoxy about the need to socially isolate and to limit economic activity, which ended up hurting a lot of other people. And the most, in science in the United States, the most visible dissent on that came in the form of the Great Barrington Declaration, which was put forward and signed by a number of prominent scientists, only to meet a kind of resistance from places like the Union of Concerned Scientists, which called that herding people to slaughter a dangerous fringe theory. That, of course, is a way of definitely marginalizing a valid, to my mind, a valid attempt at introducing elements into the conversation that were different from the orthodoxy of the moment. This is a quote from the Great Barrington Declaration: adapting measures to protect the vulnerable should be the central aim of responses to COVID-19. For example, nursing homes should use staff with acquired immunity and perform frequent testing on all staff visitors. Retired people living at home should have groceries and other essentials delivered. That strikes me as entirely reasonable. So there are a lot of reasonable elements in the Great Barrington Declaration, some with which I disagree, but it certainly was not a fringe theory. There was a herding people to slaughter. It was an attempt at introducing a divergence of perspectives, producing a plurality of voices. But we, in epidemiology and the population health science, had no space for that. A lot of that in this country, for example, around the fact that we are shutting down schools. And one particular example where attempt to open schools results in people being told we should not have to teach students to that. This is the fact that we've always known that children have a likelihood of acquiring COVID or others. So these are things we fell short, but I think the question is why we fell short on this point. What actually caused us to fall short? There are three reasons why we fell short. Number one is complex systems. Number two is our biases. Number three is that we frequently succumb to groupthink, to thinking together as a group. Just talk about each one of them. Let me start with the complex systems. We are dealing with very complex systems in populations. We've known this. We've known that the health of populations is very complex. And perhaps the good example of this is what's happened in school. And the fact that in this country, we closed school for essentially a year, and with expecting children to learn remotely. And in so doing, of course, our children have not learned as much as they should have learned. The pink here is math scores for different grades. In our system, we have grades 3 to 4, all the way to 7 to 8. You can see that. And the pink is what children learned in terms of math scores before COVID, the year before COVID, and the green is the year of COVID. You see, the green is shifted onto the left, which means that children learned less consistently in a time of COVID. That's because we had switched to remote learning. And of course, as we switched to remote learning, it wasn't all children who did not learn equally. In fact, what this shows is that there are two dots here. The dark blue dots are schools with more than 50% students of color, and the light blue dot are schools with more than 50% white students. And what you see is K through 5. These are early childhood schools for us. That's schools with more minority students, which in the United States are students who are typically more disadvantaged, who learn even less. Schools with majority students who typically have more advantage. Complex system of schools where stopping in-class learning results in particular groups being disadvantaged, and the groups that already have substantial advantage. And that schools in areas, schools where the families have a more to reopen faster. And that's the kind of, despite the fact that the death from COVID-19 for children, you see in the red, potentially less than death from many other things, including, for example, so the rate of COVID was very low, and despite that, we advised and were behind closure that delayed learning for all children, but who were already disadvantaged. This, of course, also compounds the health consequences. There's one, it is a significant protective factor for health. The way to read this is on the y-axis, you have mortality rate. It shows it in different racial groups in the United States. Just to make things simple, this is on the white racial group. All I want you to see is the slope going down with more education. Left to right, you get the more education. The lower is the mortality rate. In decisions made in society, largely by epidemiologic advice, to schools shut and to learning, what has happened in our society is that we have essentially back in their educational attainment and social, which in the long term will end up affecting. It's then wonder that we have seen protests like about destroying our children's lives, with saying things like mental health matters, which is entirely correct, which I think is an accurate display of public frustration against advice and policy efforts that did not reflect the reality of the risks we were facing. So I think that we're in complex where we had to balance these very, and we in epidemiology helping guide society in that balance. Second reason why I think we got something wrong is our biases. Ideas are biased, and we bias to the table. Now, I did make it clear that the biases don't just come in biases everywhere. I'm going to show you some American data, but you'll have Brazilian data, just don't know the Brazilian data. But let me point out for a second first that we have had tremendous biases at all levels of people who are in time of decision making around COVID. This is a picture for Congress. That means that our leaders in Washington, D.C., the capital of this country. And the reason I'm showing to show about one potential bias. What you see here is the top is Congress and the bottom is the country. And the yellow slice represents the proportion without a university degree. And in Congress, 4% of people who don't have a university degree, but in the country, we have 6% of people who do not have a university degree, showing, of course, that Congress has a very different view of the world than does most of the country on this particular area. And this mattered tremendously in a time of COVID because it is people with a university degree who did much better in a time of COVID than people without. There are other ways in which we, as academics, have had brought our own particular biases to what we did and how we thought. For one thing, we as academics, politically in the United States, are on the left side of the political spectrum. This looks at far left, left, middle, right. And what you see is almost all academics are either middle or left of the political spectrum. And being on the left of the political spectrum meant that you see the world in a particular way during a time of COVID, which again represents a set of biases. And perhaps the most dramatic bias is this. This looks at the how people did in a time of COVID, and it looks on multiple dimensions, including dimensions like mental health, personal health, physical health, personal life, work-life balance. And if you're above the line, it means those improved, and below the line, they got worse in the year of COVID. What you see here is this was a poll done at the end of 2020, is that in all groups, essentially the things are below the line, which means people got worse, except you see this spike right here, this cluster of spike, that's people with a postgraduate degree, with a degree beyond bachelor's, which is really all academics have a postgraduate degree. So we brought as academics and academic epidemiologists or government epidemiologists, all of whom have a postgraduate degree, we brought to COVID the perspective that was informed by the fact that we are better than we had done before COVID, which of course changes how we think. And finally, as epidemiologists, we are in this country disproportionately white and Asian versus having underrepresentation of Latino and Black epidemiologists, when in fact, minority populations, particularly Latino and Black populations, were the ones who were hardest hit in the time of COVID. So we brought particular biases, which I think, whether we like it or not, inform what we do and how we commend policy action. And the third point is groupthink, that we adopted groupthink. And perhaps there's many different ways of pointing out groupthink. I already talked about our perspective on lockdowns, but I will point out one particular effort, which was the effort towards zero COVID, which has been supported by many prominent epidemiologists, which is an effort that says that we are going to be able to simply eliminate COVID. There's been no reason ever to believe that we're going to be able to eliminate COVID. We have eliminated only one disease in human history, smallpox, one disease in animals. And a disease like COVID respiratory-borne virus would have no real chance of eliminating, particularly given that it has reservoirs in animals, which means it's next to impossible to eliminate in humans. To my mind, despite that, there has been this significant epidemiologic force on zero COVID, papers written in prominent journals, and countries have adopted zero COVID, which has been a tremendous policy distraction. I have written before that the zero COVID approach is akin to the mythical spherical cow in science, which some of you may have heard the aphorism that scientists say, imagine or assume a spherical cow of uniform density, which of course, the point behind that is there's no such thing as a spherical cow of uniform density. And that's an assumption that we're making. And we're making assumptions in the context of zero COVID that we can eliminate an airborne disease when we've never done so before. And of course, one country after another then went on to drop zero COVID, but not after, not before. They hadn't had, for example, in Australia, which recently dropped zero COVID, more than 111 days of lockdown is in this effort to continue promoting zero COVID. And a lot of this comes to my mind from our groupthink, from the fact that we as epidemiologists often talk to only other epidemiologists and talk to people like us in the political spectrum. And in this country, in the United States, politics is divided into red and blue, Republicans and Democrats. And just to show you one illustration of this, and you see all the blue is clustered to one side and all the red is clustered to the other side. The point is that people tend to talk only to people who are like them. And just to give you a bit more of a sense of how much this groupthink affects us, this is Suffolk County, which is up here in the Northeast United States where I live, which is in Boston. Boston is the part of the country which actually has the most epidemiologists in the country. And it is actually also, has been shown to be the least tolerant county in the country. So COVID has created opportunities for epidemiologists to just talk to one another and to come up with recommendations that seem consistent with what the people one knows, but those people one knows are actually doing better in a time of COVID, quite different than how the rest of the population has been doing. So recognizing what we did wrong and why we did it wrong, I just want to talk about looking forward now and look forward about reclaiming an epidemiology of what I call an epidemiology of consequence. I've written previously about an argument for consequentialist epidemiology almost 10 years ago now. And in there, I talked about that fundamentally, we should invest in an epidemiology that helps us make the world better. And that's what actually we should do. And I argued before for a recalibration of the philosophical foundations of epidemiology, and that epidemiology is a discipline that aims to do good. Again, we are now in the throes, or perhaps in the tail end, of a pandemic that has killed more people than any other pandemic since 1918, which arguably is a failure of epidemiology that has happened. So how do we go about improving what we do as epidemiologists? And I would argue three things: epistemic humility, radical compassion, and reform through reason. And let me talk about each one. By humility, I mean recognizing what we know and what we don't know. And I think we have been quite poor at doing that, as I've argued before, in terms of being honest about what we know, what we don't know. But I would argue that our arrogance that comes from visibility in the moment is short-sighted, because we've had periods of visibility before, and those periods of visibility never last long. To be concrete, this is a cartoon. We're saying it's typically brilliant of you to have invited an epidemiologist, showing the high regard epidemiologists were held in. But this is not right now. This was 20 years ago. The last previous period of tremendous visibility for epidemiologists was after the September 11 terrorist attacks in New York City, where there was similar visibility for epidemiologists. And that, of course, faded, as will this visibility right now. We are well served by having the humility to recognize that there's a lot we don't know, and that our role is to help provide data with proper caution to guide the world, without having the arrogance to say that these data are dispositive and false leading policy, as we've done many times. As a definition, epistemic arrogance is the tendency to overestimate our ability to predict when we're overconfident in our knowledge. And that, I think, has characterized much of epidemiology in the past year. The second is radical compassion, that we need to be deeply compassionate about the fact that our policy recommendations are potentially harming many people, particularly people who we do not know, people who are unlike us, people who do not have the benefits, advantages that we do. In the context of COVID, what does that mean? Well, recommending lockdowns to limit the spread of the pandemic does not take into account the fact that many people actually don't have the luxury of working from home. This looks at income quartile in the United States, more income and your ability to work remotely. And what you see is the more income you have, the more likely you are to work remotely. Epidemiologists are also on the right side of this curve. Epidemiologists are in the top quartile of income. So we actually have ability to work remotely, which makes it easy to say we should work remotely. But of course, the majority of the population does not have that flexibility. So when we're prescribing lockdowns as a way of limiting the pandemic, we see that as a reasonable and realistic approach. But in fact, it's not for the majority of the population. It's our responsibility to think of other ways the pandemic can be limited, rather than ways that simply do not work for the majority of the population, who then are at higher risk of COVID themselves. Because, of course, the implications of lockdown has been this dramatic job loss in this country, which, again, has not affected people in high-wage employment. You see there was a dip, but then recovery in high-wage employment, with 10% more employment. But it has affected people in low-wage employment, where employment remains 20% what it was before COVID. The lockdown efforts and the efforts to mitigate COVID as recommended by epidemiology today has resulted, for example, in things like this in the United States, with this tremendous increase in drug overdose. That's with 93,000 deaths from overdose in 2020. And in fact, in the March to March period, when COVID started, with 100,000 deaths from overdose in this country, 30% more than it was the previous year. And a lot of that, of course, was fueled by people being inside in lockdown, and the rise in mood anxiety disorders and isolation and loneliness. So finally, epidemiology should be part of an effort to reform and reason, to provide data that allows us to aspire towards a radical vision of the world, a radical vision of a world where we are healthier, where we are able to mitigate threats of viruses like COVID-19, but do that slowly through incremental, thoughtful efforts that build on reason and data. I've actually written about this. Anybody's interested about radical vision and incremental approach to achieve the aspirations of public health. And if I may end on, this is a book that I just had that just came out in the United States 2 weeks ago, The Contagion Next Time, which really talks about what we should have done in context of the pandemic in many ways, but in particular, half of the book, but the second half of the book is about these topics framed about what we should have been doing in public health and should have been doing better. Thank you. I really am delighted to be here with you. I'm honored that you invited me. And I very much look forward to meeting again in person where we can have this conversation. I want to thank you and the Brazilian Congress of Epidemiology for inviting this conversation.
Thank you very much, Dr. Sandro Galea. It's our pleasure to have you here. And I would like to thank you again, your kindness to restart your lecture in order to have our audience to have your brilliant lecture for us. So thank you very much. And I hope to see you in person.
I would very much look forward to that. Thank you again.
Thank you. Thank you very much.
Bye-bye.
Bye-bye. Em nome da Abraço, então eu gostaria de agradecer a todos que nos assistiram e convidá-los para o próximo, para as mesas redondas que acontecerão seguida desta conferência. Muito obrigada por estar aqui conosco. Queria novamente aí agradecer a todos vocês que ficaram aqui e pedir aí as nossas desculpas. Os eventos virtuais são assim, a gente fica... Isso pode acontecer, né, essa queda da internet, mas agradecer a presença de todos e todas aqui. Muito obrigada.